Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of 10 Clinical Minutes is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represent those of the participants and not of any of our affiliated institutions. Also, a big thanks to Justin Kugel for his editing, support, and creative contributions.
Thank you for joining us on 10 Clinical Minutes. We've been learning so much through this whole process, and we are so glad to have you learning alongside with us. Now, let's get to the episode. All right, we have a presentation this morning on CT pulmonary findings. So to start off, some terminology. So anytime you are reading a radiology report, oftentimes there's lots of big words and we don't quite know what they mean. So that's kind of the goal of this presentation. And to start out is the basic terminology that they'll use. So an opacification is basically a whitening. So it's something that is there in the tissue that is blocking the x-rays, that's causing some more white than normally would be there. So these terms are always in reference that what should be there. So an opacification is a tissue that normally would be darker, but now it's lighter because of something there. A lucency is the opposite. It's something that normally would be filled with something, and now it's more air-filled than normally. So it's more black than normal. Sometimes this could also be something that's fluid-filled, but in general, it's something that is less dense, that is filling that space compared to what's normally there. So to start off, the term consolidation. This is a term that you will hear and read all the time in the radiology reports. So a consolidation is a pathology of the alveoli. So something's going on, something is filling those air spaces. And that what's filling it could pretty much be anything. It could be pus, it could be just fluid from edema, it could be blood, it could be cells like from malignancy or from inflammation, it could be inflammatory cells, or it could be surfactant. So what you're looking for on CT to identify consolidation is this just opacification of the air spaces. So you see down here this just confluent whiteness. It's just filled and there's something there. And if you notice, it's also in this patient is dependent, meaning it's the part of the patient that's gravity down is what's filling. So in the CT scans, we always are looking at the patient from their feet and they're laying on a table. So their head would be looking up this way and we're looking through their feet. So this would be the bottom of the table. And then another thing that you can see with consolidation that you'll hear on the radiology reports is the air bronchograms. So the bronchogram is basically the bronchi that are going through the lung that normally you can't really see very well because the air spaces in the alveoli around them are also black. And so black on black, you can't really see the bronchi. But when there's a bunch of fluid or a bunch of stuff that's filling the air spaces around the bronchi, you can suddenly see them. And so that's what an air bronchogram means. It just means that we can see the bronchi that normally we didn't see before in the periphery of the lung. So there's a lot of things that can cause consolidation. The big things that we think about would be pneumonia, pulmonary edema, diffuse alveolar hemorrhage, basically anything that can suddenly fill the lung up with something. More chronically, you can also get this with like cancers and other chronic diseases, but this is typically more of an acute thing that we see. Next up is ground glass opacities. This is another big one that you'll see on radiology reports. It's kind of one of those terms that I think a lot of people kind of throw around and don't always completely know what it means and just kind of smile and nod. So a ground glass opacity is something wrong with the alveolar wall and the interstitium between the alveoli. So there's something inflaming that section. So on CT, you're looking for this very patchy opacification, but it's still going to have the vascular and the bronchial markings. So you can see, if you kind of think, if you've ever seen ground glass, meaning you have glass and someone's grinding it up or stepping on it, it kind of has this real diffuse shadowed appearance. And so that's kind of what we're getting here, like on this part of the lung, where it's just kind of this very patchy appearance. And what that's telling us is that there's inflammation in the alveoli and in between the alveoli that is causing something. So it could be pus, it could be fibrosis, it could just be like thickening from inflammatory cells, it could be all sorts of things. Most commonly, PJP is known for doing this, pneumocystis pneumonia. COVID-19 is also showing us that it can do this. Diffuse pulmonary hemorrhage, and then lots of viral pneumonias will cause this type of a pattern. or chronically. We see this a lot in just like interstitial lung diseases, which would make sense if this is a pathology of the interstitium. We'll also see this in any sort of like fibrosis, including like sarcoid. Next up are reticular opacities. So these are something wrong with the interstitium. So this is just the part of the lung between the alveoli, the walls, or if you're looking at like a pathology slide, it's the actual parts that you see filled with stuff in between the air spaces. So reticular opacities are caused by something filling up that area. So that, again, could be fluid, it could be cells, or it could just be fibrosis. So on CT scan, we're looking for these very linear opacities. So if you look at these, it's kind of like someone took a pencil and just kind of started outlining things on the lung. So these are these very fine lines that are appearing as opacifications, meaning that there's inflammation just in those walls that are in between the alveoli. Again, think back to those pathology slides. If we're learning about the lung, you see those walls in between those big air spaces, and that's what's going on here. Some common causes of this, you can have all sorts of infectious causes. Oftentimes we think of community-acquired pneumonia, atypical pneumonias that actually infect that interstitium as opposed to the alveoli. So that makes sense that would cause reticular opacities. Other viral infections can do that. Pulmonary edema, depending on the cause, can kind of concentrate in the interstitium. And then more commonly, we see this chronically with like a post-infectious scarring. If you had a bunch of inflammation going on for a while in the lungs, it's going to leave some stuff behind. So it's going to cause some scarring. We also see this with autoimmune diseases like rheumatoid and sarcoid, and then drug reactions can also do this pretty commonly. Next up are nodular opacities. So in my opinion, I think nodules are kind of the radiology version of idiopathic, not quite sure. So this is typically a pathology of the interstitium, but it can also be of the airspace. So basically, it's just some collection of something that we're not quite sure what it is. And it's of a certain size, so we can define it. So on CT scan, we're looking for basically small round masses. Sometimes they're smooth if they're in the pulmonary space. Sometimes they're a little irregular if they're in the air spaces. It's basically just something round that we don't know what it is. So this can be caused by infections. This can be caused by granulomas, by hamartomas, by metastases. We'll often see like a nodule be the first term that is reported on a radiology report before someone is then worked up for cancer, because there's a lung nodule, there's a pulmonary nodule. But it doesn't have to be cancer. It can be pretty much anything that can accumulate in a little defined space in the lung. Next up is tree in bud. You'll hear this thrown around a lot. Basically, this is something is wrong with the distal airway or the vasculature, one or the other. And you can kind of see on the CT scan why they call it tree in bud, because it looks like a branching tree. And then at the end of this tree, there's little tiny nodules that kind of accumulate around and kind of look like the little leaves on the end of this tree. So that's why they call it that. Some common causes, I'll actually start with the vascular ones because it kind of helps the concept make sense. One of the big vascular ones is tumor emboli. So if you think about the vascular bed like as a net, and then you have some tumor somewhere that's throwing emboli into that net, the emboli are going to get caught at the very ends. And so you can kind of think of the tree appearance as the net, and then the emboli as the little parts that are caught at the end of it, causing the buds in this tree. You can also see this if someone has injected anything into themselves, any foreign material that has then traveled through the vasculature up into the lungs. Same concept, it's caught in the neck. The more airway-centered diseases where we see this more commonly, you can see it in TB, aspiration pneumonia, all sorts of different viral pneumonias, fungal pneumonias, cystic fibrosis, and it's a similar concept. I think it's less intuitive to understand in the airways, but it's the same general thing, is that you have small pieces that are downstream at the end of one of our branching patterns, which in the lung is the vasculature or the airway. Next up, we have cystic lesions. So this is something wrong in the air spaces and the interstitium, kind of like other things we talked about. So on CT, we're looking for these very thin, well-defined walls with mostly air inside them. So you can see pretty big ones over here. There's a bunch of small ones over here as well, including some kind of in this middle mediastinum space. There's some on this left side as well. So I think most of us are fairly familiar with cystic lesions, but it can be caused by a lot more things than we think. So I think a lot of us will think of emphysema, but it can also just be caused by fibrosis, by various atypical infections, by anything causing chronic inflammation of the lung, including many like just chronic lung diseases, autoimmune and otherwise. And basically there's just been so much inflammation that it's kind of destroyed some of this airspace, and that just creates this kind of big bubble, because instead of having a bunch of little spaces, we've destroyed a lot of the walls between them, and so they just kind of consolidate into a big bubble, and that causes the cystic lesions that if they get big enough, they can become bulla. Honeycombing is another common phrase thrown around that most people don't always know what it means. So honeycombing is something wrong with the air spaces primarily, but in reality, honeycombing is the end stage of a lot of chronic lung diseases. So what we're seeing with honeycombing is these very enlarged cystic spaces with thick walls, and they're often filled with stuff, whether it's inflammatory stuff or other things. So you can kind of see in these distal parts of this lung, we're seeing these, it's a variety of cysts, but they're all very clustered together, and there's very thick walls between them. So you can see like there's one here, and all this between them is very, very thick. As opposed to the cystic lesions over here, you see these walls are super thin. That's more of a cyst. But when it's honeycombing, they're pretty inflamed, and so you've got all this fibrosis and thickening between them. So like I said, this is kind of an end-stage fibrosis. So anything that can cause fibrosis can cause honeycombing. So we can see this oftentimes with bronchiectasis, which is just long-time chronic inflammation from chronic infections, oftentimes in the lung. We can also see it with like idiopathic pulmonary fibrosis, sarcoidosis, cystic fibrosis, anything that causes inflammation for a long time in the lung. Speaking of bronchiectasis, as you would maybe presume from the name, this is something wrong with the bronchi. So similarly, this is chronic inflammation that leads to bronchial dilation and thickening that makes it basically stay bigger than it should for deeper into the lung. So on CT scan, we're looking for what's commonly called tram track sign, which means that we can just see these dilated bronchi go farther into the lung than they should, farther into the lung than they're used to. So a lot of times with bronchiectasis, it's kind of one of those things on CT scan where you can just look at it and say, that's weird, that's not normal. And that's because we're not used to seeing these bronchi go that far into the lung. That's one of those things that as we see more and more CT scans, you get more and more used to what's normal, what's not normal. And so when you see a not normal, you pick it up. You can't always put your finger on it, but you can pick it up. So some common causes, basically anything that can cause chronic inflammation of the bronchi. So we see this, one of the classic ones is cystic fibrosis. Unfortunately, they will get pretty extensive bronchiectasis. After infections, after chronic infections, like TB, you can see a lot of this, again, if there's chronic inflammation. Various autoimmune diseases. A big one is obstructive lung diseases, so COPD. And then if you have like a chronic cancer, that can cause this as well. And then finally, post-transplant. This is one of the findings of kind of a post-transplant chronic rejection pattern that they can see in lung CTs. And finally, our last one, I had to throw in the COVID lung because this is becoming its own kind of thing in the radiology world, the radiology literature. So the most classic finding of COVID lung that we are finding is bilateral, multifocal, meaning multiple different spots, and primarily peripheral ground glass opacities. So you can see in this example lung that I have here, you just kind of got these different patches of what looks like ground glass, like someone was stepping on a bunch of glass, and it just kind of becomes this really patchy, nondescript. I think you can see it really well down here. It's just patchy. And it's kind of all over the place. In this lung, it's a bit more diffuse, but I've seen a lot of lungs where it really is just kind of around the outside, around the periphery of the lung. Another thing that they're describing in the literature is this crazy paving is what they're calling it. And this is like a thickened interlobular and intralobular opacity with ground glass as well. So it's often combined with the ground glass, which makes it kind of hard to distinguish sometimes. And honestly, I think this is way over the head of most general medical students and even practitioners. And this is something that the radiologists are using to communicate with each other, which I think is super awesome. In my opinion, it's more of something to recognize in your radiology report as a finding that is associated with certain things, including COVID. I think it's a little above our heads to understand what it actually means. And finally, you can see the vascular dilation and the bronchiectasis. So here's another example of the bronchi that's just going a bit deeper into the lung than it should. You should not see that black line going that far out. And then vascular dilation, like you can see over here in this lung with all these kind of white branching lines that are appearing, showing that the vasculature is getting big. And then finally, just this chart from Radiopedia that just shows some of the patterns that they're seeing in COVID-19 pneumonia. So again, ground glass opacities are super, super common. You're seeing it distributed more in the periphery and in the back of the lungs. Oftentimes it's involving multiple lobes, multiple lungs, different kind of patchy spots. And then, yeah, peripheral. And then sometimes you're seeing consolidation, but not as commonly. So big thanks to Dr. Cox. He helped me check this PowerPoint for accuracy. And then I got all of my images from, mostly from Radiopedia, a few from UpToDate. So big thanks to those awesome resources. And that's all I got for today. So thank you all for joining us on 10 Clinical Minutes. It was a pleasure to have you guys here. Hope you were able to learn a little bit. I think this is the type of presentation that maybe go back through if you need some extra time to kind of digest what was there. But hopefully it'll be a little helpful to read your own radiology reports, look at your own images, and kind of put together the pieces to try and understand what in the darn they are saying on those reports.